name is Sara Salim. I'm a third-year medical student here at MBRU, and today my presentation will be on differentials of patients presenting with acute dyspnea. We'll be looking at their history, their examination, and their radiological images. We'll also be discussing certain parts of their management and their treatment. So starting off, I wanted to thank Dr. Jania, who is also a radiologist from MedClinic, who is joining us on the call today. I also wanted to start off with this slide that shows basically, this slide shows you the causes of the two systems involved in acute dyspnea, which are the cardiovascular and the respiratory system. In this session today, we'll be focusing on the respiratory system end of things. I will not be able to cover all the examples. However, I do have 5 main cases, and we will be discussing their different classifications and variations of every case. Okay, so starting off, I wanted to review the chest systematic approach used to read X-rays. We had a session on, this was our first session from the Radiology Club. However, I wanted to go through it quickly, just as a revision. So first of all, you would start with the patient's ID, and you need an identification, either the ID number of the patient, their name, or their medical record number to make sure that you are identifying the correct patient. Second would be you look at image quality. And if you remember, image quality has 4 major parts. So the first being the projection. So what are the 2 different modes of projection that we have? You can answer by either opening your mic or I guess I can see the chat on my phone.
AP and PA?
Yeah. So essentially, it's AP and PA, 2 types of projection. We'll be discussing the details on that later on. We also have penetration. We will talk about rotation and inspiration of every patient. Regarding airway, we look at the major trachea. Regarding breathing, you look at lung field density. We look at the hyperinflation and so on. With circulation, we look at the heart borders, the mediastinum and the aorta. And for the diaphragm and delicates, we look at the diaphragm, the costophrenic angles, the ribs and the bony structures, along with the soft tissues. And for extras, we look at things like ECGs, vascular lines, that may tell you more about your patient's case. We're going to start now in the first case, and what I want from this session is for you to be able to build a list of differentials in your mind, maybe eliminate certain differentials, add some differentials onto your most likely list, and add some onto your least likely list, okay? I'll start with the history. We'll go through vitals and their examination, and then we'll look at the radiological image and maybe give an insight on the disease itself. So first of all, we start with a 30-year-old female who presents to the emergency department with sudden onset of right-sided pleuritic chest pain and breathlessness. So remember, first we have a 30-year-old female. This patient is not a child and is not an elderly patient, so you may eliminate certain maybe genetic conditions that appear or would be diagnosed in a child, and have to consider a lot of things when you're dealing with an elderly patient, whether it was for diagnosis or for management. This is an average adult. She's a female. Remember, some diseases are more common in females than males and more in males than females, and so you have to note the gender of the patient. And she came with sudden onset, which goes under acute, which is our main topic for the day, of right-sided pleuritic chest pain and breathlessness. These were her 2 symptoms for today. She has no significant past medical history. Remember to note the past medical history because for example, if this patient was asthmatic, something that you would consider is an asthma exacerbation, okay? And so past medical history is very important to note in your patient. In this case, she does not have any past medical history. She's also a non-smoker. Remember, smoking is taken under social history, and it's very important to take it in terms of a respiratory examination and history taking. And that was it for her history. Now, on examination, she has a saturation of 91% in air. So if you remember, the vitals include things like oxygen saturation, the temperature, the heart rate, the respiratory rate, and the blood pressure. So she has a 91% in air oxygen saturation. Is that considered normal or abnormal?
It's abnormal.
Yeah, so it is considered abnormal. What's the normal values? Does anyone know or remember?
Is it 98?
I think 95 and above would be considered normal. So 91, she's on the low side in terms of oxygen saturation. And she's also afebrile. And afebrile meaning she has no fever. What does fever essentially indicate?
Infection.
Yeah, exactly, infection. And so this patient, in your differential diagnosis list, you would kind of put infection lower on the list since she's afebrile. Her heart rate is at 92 beats per minute. Again, normal or abnormal?
It's normal.
It is?
Normal.
Yeah, so it's considered normal, as the normal rates are between 60 and 100 should be normal for your patient. And her blood pressure is 120/80, which is ideal. Her vitals. Now we move on to examination. In examination, I wanted to explain the 4 major parts of examination. So first, if you remember, patient physician. So you look at the patient physically, how they look like with regards to scars, maybe certain deformities that you may notice on the patient. Okay. Second would be palpation. In palpation, you look at 2 certain parts. First being the trachea. So you would palpate, meaning touch their neck to check for a central trachea. Just do a chest expansion test. And the third part of examination would be percussion. You tap on the patient's chest and you check for resonance of sound. Okay. Essentially, we treat the lung, since the lung is filled with air, sound that concept to a drum. So when you tap on a drum, there's a resonant sound that comes out. However, when you have increased in this drum, a different sound would come out, and that would be called hyperresonant. Okay. However, if this drum is filled with fluid, for example, it won't give the same sound out, and that would be called dullness. In this case, we have an increased resonance in the right hemithorax. Increased resonance meaning more air or more fluid?
More air.
More air.
More air. So this is increased resonance in the right hemithorax and reduced air entry. The last part of examination was auscultation, where you use a stethoscope to chest different parts of the patient's chest. In this case, we have reduced air entry, meaning that we don't have abnormal lung sounds. However, we cannot hear the normal lung sounds either. Okay? And this was the patient's chest X-ray. So give me a second. Okay. So can you see my pointer? Yeah.
Yes.
Can you see it?
Yes, Sarah.
Okay, so what you see here, first of all, if you remember, we talked about patient ID. Here are anonymized, so you can't D here. What is the projection of this image?
AP.
Yeah, so it's an AP projection. When do we use an AP projection?
Usually when you can't really move the patient or in an emergency case and you want a quick X-ray.
Yep, exactly. So that's when we would use an AP projection. If you notice here, the penetration is okay. So the vertebral bodies here, how do we measure the penetration? Vertebral bodies are visible right behind the heart. So vertebral body visibility is what tells you if the penetration is adequate or not. How about inspiration? How do you measure if inspiration is normal?
The ribs. You count
Yeah.
the ribs.
Yeah, exactly. So you count the anterior ribs. 7, 8 should be quite adequate. Okay. How about rotation? Does anyone remember how do we if the patient is rotated or not?
I think it's
Based on the... Go for it, Chad.
no, it's fine.
Based on the patient's clavicle and the distance from the spinal cord?
Yeah, so basically we treat the spine as the midpoint, and the clavicles increased distance to one side, that would be rotated to that specific side. So in this case, our patient is rotated slightly to the right. Then we will look at the airways. We talked about the trachea. So the trachea here is a little bit deviated opposite to the direction of the issue, clearly. This can be due to the rotation or due to the issue we have here. Now moving on to the lungs. If you notice here, the lung edge is visible. Okay, over here on the right side, okay, beyond which no lung markings are seen. So if you notice on the left side, you can see the lung markings extending all the way through. However, on the right side, you can see that this right over here, you can mark where the lung really ends. Okay, and this is consistent with a large pneumothorax. Okay, there's almost complete collapse of the underlying right lung. The left lung, however, is clear. So you can see here almost a normal versus abnormal hand in hand in one patient. You can see that there's complete collapse of this right underlying lung. And we said that the left lung is clear. We don't see any hyperexpansion in both lungs. The left pleural spaces are also clear, and there's normal pulmonary vascularity. If you notice here, the heart does not appear enlarged. But why can't we measure the heart size specifically?
Because it's an AP projection.
Exactly. So because this is an AP projection, the heart size is accurately assessed in there. It's kind of projection. Now, the right heart border is kind of difficult to identify due to this underlying collapsed lung. Quite clear. The left border, it's quite clear. Okay, the left heart border. In terms of the mediastinum, we're talking, it's a central mediastinum. Okay, it's not widened and it has quite clear borders. Hilum, however, is difficult to identify, again, due to the fact that the underlying lung is collapsed. You can see that there's normal size, position, and costophrenic of the left hilum. We have normal appearance of the hemidiaphragms. Okay, we can see the costophrenic angles very clearly. And we have the image skeleton is intact. We don't see any fractures in the bones, and the soft tissue is unremarkable. Okay, we don't see any vascular lines, tubes, or surgical clips in this patient. To summarize our findings, basically we have a large pneumothorax on this side. We have an underlying collapsed lung. We have a right heart border that we said may be difficult to identify due to the underlying collapsed lung. We have normal right and left hemidiaphragm, a clear left heart border, a clear left lung, and we have a trachea of a mediastinal shift that may be due to the patient's rotation or due to the lesion we find here.
Sara, can you show the carina on that picture? Show the.
Yeah, okay, doctor. So
So let me, yeah, so come here, faint green light there for the trachea. Follow it, you can, if you follow it, you can see that this is the carina, how it's shifted to the left. You see that? Yeah. So that's basically the carina. So this gives you also a clue how much of shift is happening here. Although this is an AP projection, the size of the heart is still normal because she is young.
Yes.
And we're basically measuring from here to here. Yeah, that's fine. Go ahead.
Moving on, I wanted to explain the general concept of pneumothorax. So basically, in the pleura, the concept of pneumothorax, we have pleura. In the pleura, we have two layers, a visceral pleura and a parietal pleura. The visceral pleura is one that's attached to the lung itself, and the parietal pleura is one that is attached to the chest wall. Pneumothorax can be classified into three different. So essentially, you can see the spontaneous pneumothorax, a traumatic pneumothorax, and an iatrogenic pneumothorax. In this patient, what do you think the case would be? Of all of these, so would it be spontaneous, traumatic, or iatrogenic? So if you remember, spontaneous is basically it's just a bleb on the lung surface, and happens in how it happens. In traumatic, it's the one that you have basically a trauma, like a car accident or a wound or something like a wound. And in iatrogenic, it's one that's in the hospital, something that happened in the hospital. So thinking in terms of the type here.
Maybe spontaneous, because there's no other injury.
Yeah, so if you remember, this patient didn't have any past medical history, so it is spontaneous pneumothorax. So would it be primary or secondary? So in this case, it would be primary, because if you remember, again, the patient didn't have any past medical history. So since she didn't have any past medical history, it's spontaneous pneumothorax. And basically, spontaneous pneumothorax, it's a rupture of a bleb on the lung surface that allows air to enter the pleural space from the airways. However, what you can see here, on the other hand, what is, can you identify this structure?
That's a pacemaker, yes?
Yes, so this is a pacemaker. So this is, for example, a 70-something-year-old patient came in for this pacemaker due to in the cardiology ward, and after the installment of the pacemaker, she felt left upper-sided pleuritic chest pain. So which type would that be? Spontaneous, traumatic, or iatrogenic?
Iatrogenic?
Yeah, so it would be iatrogenic. So this is a iatrogenic left-sided pneumothorax secondary to the pacemaker insertion. Okay, how about the management of pneumothorax? What would you do for your patient? So essentially, you would start by obviously, yeah, who can go on?
Yeah, so since there's a lot of pressure building up, we need to relieve that pressure so you can puncture the lung. I think, like, with a needle.
Yes, exactly. So obviously the patient should be given supplementary oxygen. You would start off with a needle aspiration, and depending on the size of the pneumothorax, you may need a intercostal chest drain. Okay. Do you have any questions regarding this case, or is it clear?
It's very clear for me.
Okay. Moving on to the second case. So in this case, we have a 40-year-old female. She presented to the emergency department with 1 week history of cough, fever, along with shortness of breath. So a 40-year-old female, we would consider her, again, similar to our previous patient. She's an average adult. Again, remember to note the gender of the patient, as some as a male or more common in females than males, and the opposite is true. She has a 1 week history, which is still considered acute, of cough, fever, and shortness of breath. So with just this history, what are we thinking in terms of differentials?
She probably has some kind of infection.
Yeah, exactly. So this is would be on the top of our list. So again, she has no significant past medical history in this case. She's also a non-smoker, and we talked about why noting if she's a smoker or non-smoker is very important. On examination, she has a saturation of 85% in air. So we talked about oxygen saturation in the previous case. Again, is this normal or abnormal?
It's abnormal.
It's abnormal. Again, it's on the low side here. She's febrile, so with a temperature of 38.2 degrees Celsius, and we said how being febrile basically is an indicator of infection. She has dullness to percussion. Opposite to our previous patient who had hyperresonance, this patient has dullness to percussion, and we will look at the radiology now to see what is causing this dullness. The crackles in the right lower zone essentially is an abnormal lung sound, and due to the limits in time in this presentation, I won't be going into details on that. However, this is an abnormal lung sound that's heard in the right lower zone, and we did for pneumonia Xray to check for pneumonia, a collapse, or an effusion. And what you see here in this case, you can see, I told you how patient IDs in these cases are anonymized. However, you always have to check for your patient ID. In this case, the projection is PA. Penetration is quite adequate. You can see the vertebral bodies visible right behind the heart. In terms of inspiration, it's also quite adequate. We said that we count the anterior ribs for inspiration, and this is also quite adequate in this case. And with regards to rotation, we also talked about how we measure rotation in terms of the distance between the clavicles and the midline. And in this case, the patient is rotated to the left. With regards to the trachea, what are we thinking here, central or deviated? So the trachea essentially is, you can see it right over here, and it's quite central. Patient. What you see is that there's a heterogeneous airspace opacification here in the right lower zone, and this is consistent with a validation of the right lower zone. Otherwise, the lungs are quite clear. So you can see the lung markings up here and over here are quite clear. You can see that there's no hyperinflation in phrenic angles. How about the costophrenic angles? We can see a little bit here of a thing. Basically, it's a small right pleural effusion, maybe. Okay, and the left-sided pleural spaces are clear. Everything on the left side essentially is clear, and she has normal pulmonary vascularity. In terms of the heart, this is a PE projection, so we can measure the heart quite efficiently. And in this case, the heart is not enlarged. The right heart border is largely clear, except for this inferior margin, where it's a little bit so visible. It can be a little bit indistinct due to this consolidation. However, we have a clear left heart border here. The aorta appears normal, and the mediastinum is central. It's not widened, and we have normal positioning of the hilum also on ends. The right hemidiaphragm is a little bit obscured by the consolidation here, and we said that we have normal positioning and an appearance, though, of the left hemidiaphragm. Again, we have a lateral case where the lesion is essentially only on one side of the thorax, and the other is the normal end in this case. Again, we talked about the image skeleton. We have to examine that, and in this case, it is clear. We don't see any fractures or destructive bony lesions. The soft tissue, the visible soft tissue, also in the image is unremarkable, and we don't see any vascular lines, tubes, or surgical clips. So to summarize our findings, we said that the trachea here is central. We said that we have a right lower zone consolidation. We said that we have a little bit of an obscured margin here, Due to this consolidation, we may have a small right pleural effusion. We have a clear left heart border, a normal left hemidiaphragm, and an obscured right hemidiaphragm. So we have essentially the consolidation, and on the left side, everything is quite normal. So regarding pneumonia, we can discuss pneumonia. It's basically an infection, okay, of one or both sides of the lungs. It can occur in one or both. It can be of bacteria, viruses, and fungi. Okay, many things can cause it. The infection basically causes inflammation in the air sacs in your lungs, which are called the alveoli. Okay, the alveoli, they fill with fluid or pus, making it difficult to breathe. Okay, so pneumonia can be divided and classified in different ways. One of the ways we divide it is through the pathogen causing it. So it can be typical, atypical, or viral. Does anyone remember the most common type of typical pneumonia? So it's Streptococcus pneumoniae, if you remember from last semester. How about atypical? Does anyone remember the most common type of atypical pathogen causing pneumonia? So that would be mycoplasma pneumonia. Anyone remember the correlation to plasma to a certain group of patients?
Is it the walking pneumonia?
Basically, mycoplasma is correlated with HIV patients. So a lot of HIV patients come in with mycoplasma. How about according to location? So according to location, we can divide it into lobar, interstitial, and bronchopneumonia. So in this picture, I just wanted to show the lobar pneumonia. It's usually correlated with bacterial pneumonia, usually causes lobar pneumonia, while viral pneumonia causes something called interstitial pneumonia. The thing with interstitial pneumonia is it's bilateral, okay, it's symmetrical, and it gives this ground glass appearance. So what would you do for management of a case of pneumonia? Initial blood tests include, you would do some blood tests. Would you culture in a case of pneumonia?
The organism?
Yeah, like a sputum culture, maybe obtained from the patient. Okay, you would treat them with the appropriate antibiotics and do a chest X-ray follow-up 4 to 6 weeks later to ensure resolution. Okay, all clear regarding this case?
Yes, all clear. Thank you.
Okay, moving on to the third case. In the third case, we have a 60-year-old patient. He is a male who presents with progressive shortness of breath. He has non-Hodgkin's lymphoma. Basically, in this 60-year-old male, he has progressive shortness of breath. That means it has started and it's getting worse. He also has non-Hodgkin's lymphoma, which is part of his past medical history. He's a non-smoker. Remember, we talked about how smoking is important to mention in as part of the social history, in a respiratory history taking, and in general, actually. And on examination, he has saturation of 90% in air. So again, did we say that's normal or abnormal?
Abnormal.
Yeah, so it's on the low side, and the patient is afebrile. So afebrile meaning he has no fever, okay, or a low fever. We have reduced air entry and dullness to percussion throughout the left side. And by reduced air entry, we said that we mean we don't hear any abnormal sounds. However, we don't hear the normal lung sounds either. And when we said about dullness to percussion throughout the left side, we talked about basically either fluid or something obstructing the normal resonant sound of heard during percussion through examination. So this could be a possible pneumonia, effusion, or collapse. And this was the X-ray. So in terms of the X-ray here, the patient ID, this is anonymized. We thought about that. The projection here is, again, PA. In terms of penetration, it's quite adequate. You can see the vertebral bodies, okay? In terms of inspiration, in this case, the inspiration is limited. So if you count with me here the anterior ribs, we can see 1, 2, 3, 4, and 5, which is quite limited in this case, okay? In rotation, the patient is slightly rotated to the right, and we talked about how we can measure rotation by measuring the distance between the clavicles. The trachea is deviated to the right. That can be due to the mass effect that we are going to examine now here. What you notice here, though, is a complete homogeneous opacification of the left hemithorax in keeping with a large pleural effusion. In terms of the right lung, you can see that it's clear. So again, this is a unilateral issue, okay, where you can see the normal versus the abnormal, same patient. So the lungs you can see here are not hyperinflated. The right pleural space is for this, and we have normal pulmonary vascularity, except for this large pleural effusion in the left hemithorax. In terms of the heart, the left heart border is obscured by the effusion, so you can't really see it. The cardiac size is also cannot be assessed due to this pleural effusion. And the thoracic aorta is obscured. The mediastinum is central and not widened, with a clear right border. However, the left border is obscured. Essentially, everything on the left side is kind of obscured because you can't really see it due to the large pleural effusion. So we're talking left heart border, the mediastinal borders, the hyla, everything really on this, even the diaphragm on this side, you can't really see due to the pleural effusion of the left hemithorax. However, we have normal size, shape, and position of the right hilum. In terms of the diaphragm, we said that here in the you can see it diaphragm. However, in the left diaphragm, it's quite obscured. We have normal position and appearance of the right diaphragm. The image skeleton, it's intact. We don't have any fractures, and the soft tissue looks unremarkable, and we don't have any vascular lines, tubes, or surgical clips in this case. And what you see here is a gastric bubble indicating the stomach on this side, and the liver would be under here. So just to summarize our findings, what you can see here, we talked about a large left pleural effusion. We said an obscured heart border, almost obscured anything that you can mark actually on this side, which is aka hyla, the borders of the mediastinum, and so on. And the left hemidiaphragm is also obscured. We talked about the normal gastric bubble here. On the other hand, on the right side here, you can see that there's a clear right lung, a clear right heart border, and a normal thing that hemidiaphragm. And the thing that strikes you the most here is the mild tracheal deviation that can be due to the pleural effusion pushing the trachea away.
I have one question, Sarah. Where is the left lung in that case? You have a large pleural effusion. In that case, you would expect deviation of the mediastinal structures to the right side. So we are. I love the annotations. Everything is very clear and nicely annotated. But where would the left lung be then? If the left lung was there, then we would have a lot of shift because we are occupying the space. But instead, we have the left diaphragm going higher up, and that's shown by the gastric bubble. So where is the left lung in this case?
I'm unsure. Can you point it out?
So basically, the left lung is collapsed. That's
right.
Why. And just like a balloon, you can have a huge balloon. Once you take the air out of it, it can fit inside your hand. The lung also, if you take away the air out of it, it becomes very small, like the case of total collapse that you showed with the pneumothorax earlier.
Yeah.
In this case, with a large pleural effusion, you're also having collapse of the lung. And that is happening by two mechanisms, basically by compression from the large pleural effusion and also by loss of contact. The lung expands because of its contact with the chest wall. So it's both passive and positive collapse of the left lung. So basically that's here. It's very important to point out that we have volume loss because the left diaphragm is up. And well, in spite of a huge left pleural effusion, we don't have shift of the midline, which indicates almost total collapse of the left lung.
I see. Thank you, Doctor. So essentially, similar to the concept of pneumothorax, as the doctor just mentioned, have also part of the pleura. So we have a visceral lining and a parietal lining of the pleura, and that's where the fluid essentially accumulates. In this case, you can see a different case of pneumothorax. You can see that the lung markings in the right upper lobe are clear. However, the rest of the right hemithorax here is filled with a pleural effusion, basically filled with fluid. And pleural effusions are classified under a transit date versus you do is you date findings. So what you do is you basically take a sample of the pleural fluid and send it microbiology lab, and you would check for transidative versus exudative fluid, and that's how you would get to the final diagnosis and the cause of the pleural effusion. Now, something to note here is that this patient had non-Hodgkin's lymphoma, and actually 20 to 30% of the patients who do have non-Hodgkin's lymphoma present with pleural effusions. So that may be something that you might want to note. And so essentially for the management of this case, you do certain blood tests. You would get an ultrasound guided chest drain, okay, to drain the fluid, and then that fluid would be sent for testing. And then a chest X-ray can be performed to ensure that everything has been resolved. Moving on to the fourth case, this is a 42-year-old patient who presented, he's a male, he presented to the emergency department with acute on chronic shortness of breath. Does anyone know what acute on chronic means?
He had a chronic issue, but there's an acute exacerbation of it.
Exactly. So this is someone with a chronic condition, but this is an acute exacerbation of that issue, and he came in with shortness of breath. Remember, this is a 62-year-old male patient, so this is an elderly patient, so you have to consider that in your management of the patient. He has a 50-pack year smoking history, so does anyone remember 50-pack year smoking history?
So basically, they take the person's smoking history and they calculate it based on how many packs per year would they smoke, like an estimate.
So how many packs per year over how many years did they smoke? And so this person has a long history of smoking. And on examination, he had a saturation of 86% in air. And we talked about how that could be low. And he's afebrile, so no fever. And we talked about how fever indicates infection. His respiratory rate is 20. And in respiratory rate, is that normal or abnormal? It should be considered. Go on.
It's more to the high side because the normal respiratory rate is 16 to 20.
Yeah, but it's still considered normal, I would say, but it is on the high end of normal. He has a heart rate of 90 beats per minute, which we said is normal. There's bilateral crack holes and a wheeze throughout the lungs, and these are abnormal lung sounds heard throughout. And we requested the chest X-ray, and this was it. So what you see here is that, remember we first checked for patient ID. In this case, the projection is AP, similar to our first case. The penetration, it's slightly underpenetrated. You can see that the vertebral bodies, you can see the difference between these vertebral bodies versus the ones in the cases before. In terms of inspiration, it's adequate. We have 8 anterior ribs are visible. And in terms of rotation, this patient, I wouldn't say is rotated. The trachea here is central, so the trachea would be right over here. What you notice though here is that there's an increased opacification here in the left midzone, okay, of the region, but it preserves the left heart border. You can see the left heart border clearly. That's in keeping with a slight consolidation. You can see that there's flattening of the hemidiaphragms here. Okay, so the lungs we would consider them hyperexpanded in this case. And there's coarsening of the bronchovascular markings in general, okay, throughout the lungs overall, and that's in keeping with a COPD case. Otherwise, the lungs are clear. You can see that there's mild blunting here, a little bit of the costophrenic angles, but the pleural spaces otherwise are clear. This can be due to pleural thickening. And we have normal pulmonary vascularity. The heart doesn't appear enlarged, even though this is an AP. What you see, the heart borders are quite clear. The aorta appears normal. The mediastinum is also central. It's not widened and it has clear borders. The normal size, shape, and position of both we talked about bilateral flattening in the hemidiaphragms in keeping with hyperexpansion of the lungs. And we talked about how we have to check for the images skeleton, and we don't see any fractures here in this case, and the soft tissues are unremarkable. What are the extras that we can notice in this case? Can anyone point them out?
The patient has an oxygen tube or a breathing apparatus or something?
Yeah, so over here you can see that there's oxygen tubing going on. So this is the wire, and then this is the oxygen tube. How about these? These are just ECG monitoring leads of this patient. So what you see here, we talked about the extras just now. We can see the central trachea. We basically, to note basically, are that we have hyper-expanded lung. We can see that this X-ray demonstrates generalized increased bronchovascular markings. So you can see that they are much more intense. Okay, and the hyperinflation of the lungs is over here, consistent with the COPD. We have increased left mid-zone opacification over here, in keeping with the consolidation, and the blunted costophrenic angles may represent small effusions or pleural thickening, as I said over here. Supplementary oxygen. So what would you give this patient? Basically, this is a case of emphysema. This patient has a long smoking history. Okay, and he has COPD. Under COPD, we have two main concepts, which are emphysema and chronic bronchitis. Emphysema usually appears in patients who are of his age group, who have had a long smoking history. Okay, and it causes a certain damage to the alveoli. Okay, and essentially for this patient, we have an exacerbation of his case due to infection, bacterial infection. And so essentially, you give supplementary oxygen, which was already been given. You would do certain blood tests. Maybe a sputum culture can be helpful. You'd give antibiotics, obviously, to resolve the issue, and ask them to come back 4 to 6 weeks later to do another chest X-ray to ensure resolution of the case. Moving on to our last case for the day, we have an 81-year-old female who presents to the emergency department with a 2-week history of progressive shortness of breath. She also reports lethargy and weight loss. So in this case, what are we thinking till now in terms of differentials?
Cancer, probably, because of the age and the weight loss.
Yeah, so we have a case of, yeah, so I agree, the age, the lethargy, and the weight loss specifically maybe point arms towards a lung cancer issue. She also has a 50-pack year smoking history, similar to our previous patient, which is considered a long smoking history. On examination, she has saturation of 92%. Which is still on the low side. She's also afebrile. We talked about how fever indicates infection. She has scattered diffused expiratory wheezing with reduced air entry in the right upper zone. So this is important. So in this case, we have the issue is specific to the right upper zone. Okay, you can see that there's diffused expiratory wheezing. We talked about how wheezing is an abnormal lung sound and reduced air entry, which means we can't really hear the normal lung sounds in this case. She also has crackles with quietened with deep coughing that are heard in the right upper zone. Essentially, the main issue is in the right upper zone. So let's examine her X-ray. And so this is the X-ray she came with. So you start off again with patient ID. This projection would be PA. We'd say that the patient is slightly underpenetrated. Okay. We can see that the trachea here, you can see that the trachea is deviated to the right. Okay, and we'll talk about why the trachea is deviated to the right in a second. You can see that there's a well-defined homogeneous area here of increased density in the right upper zone, the area essentially where the examinations were found to be positive. It also has a concave inferior border in keeping with an elevated horizontal fissure. So if you remember, the horizontal fissure essentially is a part of the original lung anatomy. And you can see here the line on radiology also. The remainder of the lungs, however, is quite clear in terms of the left lung or the remainder of the right lung. The lungs are not hyperinflated. So if you remember in the previous case, we saw the flattening of the diaphragms, which told us that the lungs were hyperinflated. In this case, we don't have that. The pleural spaces are also clear in this patient, and we have normal pulmonary vascularity. In this case, the heart wouldn't be considered enlarged. The heart borders are clear, so there isn't anything really obstructing in that terms. Although we do have a convex opacity here, okay, on the right cardiophrenic angle, and this is consistent with an epicardial fat pad. So due to the fact that today we're discussing more of acute dyspnea, and this won't be our focus for the session today. In this case, the aorta appears normal. The mediastinum here is central. The right hilum is difficult to identify, but it appears elevated. So what did we have? We had till now, we had tracheal deviation towards the area of the lesion. We had elevated right hilum. And what we see, notice in the diaphragm that even the right hemidiaphragm here is also elevated. Okay. Its medial aspect is difficult to identify a little bit due to this epicardial fat, but otherwise everything else is clear. The image skeleton is clear and the soft tissue is unremarkable, and we don't see any vascular lines, tubes, or surgical clips. This X-ray would demonstrate basically a right upper lobe collapse. So let's just look at the summary of the findings. So we said here that we have a right upper lobe collapse due to this homogeneous opacification we notice here. We can see the concave inferior border, okay? We can see the elevated hyla and the elevated right hemidiaphragm in this case, and the tracheal deviation towards the area of the lesion. Otherwise, everything else is clear. So in this X-ray, it demonstrates a right upper lobe collapse, okay? So this is due to the homogeneous opacity in the right upper zone, okay? With resultant volume loss demonstrated by the tracheal deviation. So what happened here is, due to the fact that this upper lobe collapsed, there's volume loss on this side of the lung, and so the trachea moved towards the side of the volume loss, okay? Opposite to the previous cases where we had issues like plurifusion and pneumothorax, where the trachea was deviated away from the issue. The hyla and the hemidiaphragm are also elevated due to the volume loss in the right upper lobe. Given the history and the findings, this can be suspicious for a proximal tumor that's compressing the right upper lobe bronchus, causing the collapse of the lung. Okay? So this is a right upper lobe collapse caused by an underlying tumor. You would give supplementary oxygen as this patient came with a low oxygen saturation. You may do certain blood tests. You may do a CT chest with IV contrast to assess for an underlying tumor. You may also do other tests for cancer staging. The patient would be referred to respiratory and oncology services for further management and to do maybe biopsies or certain further tests for her case. And then treatment may vary, including surgery, chemotherapy, radiotherapy, depending on her case and the patient's wishes. And so essentially, this is just an illustration, really, of what may be going on, but on the right bronchus, really, not on the lung. And what I would say is that, how about this X-ray? This is a different version. So here you see this here is a large rounded right upper lobe lesion. Okay, and what you see here that it's associated with smaller nodules. If you notice here, there's smaller nodules all around, really. Okay, on the left lung. So this X-ray, it demonstrates a large rounded right upper lobe lung lesion that's associated with multiple smaller nodules, and this is highly suspicious for a upper lobe primary lung cancer that has lung metastasis. And what we mean by metastasis is that it is spreading throughout the lung. Okay, so that really ends it in terms of the presentation today. This was the book I used in terms of the cases. I highly support using this book because it does have intermediate, advanced, and basic or beginner cases. So I feel like if you want to practice more chest X-rays, this is a very good book to use. The other resources or references are in the notes section in the PowerPoint. Thank you very much for coming to my presentation today. If you have any questions, please do email me, and follow the MBRU Radiology Club Instagram. Thank you so much, Dr. Rania, for joining us today. Do you have any further comments or remarks?
That was amazing, really excellent quality. I can't believe you're only a third-year student. That was really excellent.
Thank you.
Done. Well done.
Thank you. Thank you, everyone, for coming. Does anyone have any questions?
I just have a comment.
Sure.
Sara, thank you so much for the presentation. I actually forgot many of the things we took, but I think this presentation was really helpful. It made it easier to remember a lot of things I've taken last year, actually.
Okay, thank you, Noor. Thank you, everyone.
Yes. Thank you so much, Sara.
Thank you, Ghazal.
It was a really good
for coming.
Thank you, Sara. It was amazing.
Thank you for coming.
We really enjoyed it. Thank you, Sara.
Thank you, everyone. So I think we have a class in 5 minutes,
Thank
so
you.
I guess we have to join. Thank you so much for coming, and hopefully we'll do other presentations for Radiology Club. Please do follow up with me if you have any questions on my email. And thank you for the Radiology Club team. I'd also like to thank Dr. Rania once again for joining us today. And that's about it. Thank you, everyone.
Thank you so much, everyone, for coming. And please
feel free to fill in the feedback form so that we could continue to improve the sessions. Thank you.